Here, this is the Subcommittee on Sports-Related Concussions in Canada, and it's a subcommittee of the Standing Committee on Health. Today, we have some limited time. There may be votes coming up in the House. We have asked the members for consent that we would all leave and go to vote 5 minutes before the vote, so to give our witnesses as much time as possible. Joining us today, we have Catherine Schneider. She's the Assistant Professor of Integrated Concussion Research Program at the University of Calgary. Welcome, Ms. Schneider. And we have also from the Complete Concussion Management, Inc., Dr. Cameron Marshall, the founder and president of the organization. Welcome, and now, Ms. Schneider, you would have time to make your opening statement, and then Dr. Marshall, and then we'll go right into questioning from the members. Appreciate it.
Okay, thank you. Thanks so much, and thanks for the invitation to present to the group today. On behalf of the Integrated Concussion Research Program at the University of Calgary. Concussion is one of the most common injuries suffered by children, adolescents, and young adults, with an estimated 250,000 concussions occurring each year in Canada. While the majority of individuals recover in the days to weeks following concussion, up to 30% suffer symptoms and functional difficulties that last for more than 1 month. Concussion can lead to reduced participation in sport and recreational activities, increase in risk of overweight and obesity, and ultimately increase the risk of chronic disease. Alternatively, staying physically active across the lifespan has many known benefits. Ultimately, the collaborative aim of our program is to minimize the public health impact of concussion across the lifespan through scientific discovery and evidence-informed practice and policy regarding concussion. The ICRP is a university-wide initiative at the University of Calgary, includes experts from kinesiology, arts, the Cummings School of Medicine, with support from the Alberta Children's Hospital Research Institute and the Hotchkiss Brain Institute. Concussion is a heterogeneous injury, and an interdisciplinary approach is imperative, i.e. we have many different researchers and clinicians that work together, each of whom have differing areas of expertise as part of our collaborative team. Many of our researchers are also clinicians and collaborate to answer critical questions, thus creating a very unique environment and leading to groundbreaking research and clinical work. The research success and impact at the University of Calgary is also a testament to our strong and sustained clinical, community, industry, education, and sport partnerships, national and international collaborations, and our robust training and education program for the next generation of researchers in concussion. The ICRP addresses concussion across the spectrum of injury and includes critical research questions related to prevention, diagnosis, prognosis, mechanism of injury, and rehabilitation. I'll share with you a couple of highlights of our research program. Prevention. Ultimately, if we can prevent concussions from happening in the first place, we're going to decrease the public health burden from concussion. Over a decade of concussion prevention research and sustained partnerships with the hockey community, including Hockey Canada, Hockey Calgary, Hockey BC, and others, has characterized the work of my colleague, Dr. Carolyn Emery, chair of the Sport Injury Prevention Research Centre at the University of Calgary. As a result of her work, an evidence-informed body checking policy change occurred nationally in 2013. A 70% reduction in the risk of concussion was found following a national body checking policy change disallowing body checking at the Pee Wee age groups, which is 11 and 12-year-olds. This translates to an estimated reduction of 580 concussions in Alberta and 4,800 concussions in Canada, just in the 11 and 12-year-olds alone per year. She was also the lead author on the systematic review evaluating the prevention of concussion that informed the 5th International Consensus on Concussion in Sport. Another example of policy change that's been informed by our research was also presented at the 5th International Consensus Conference on Concussion in Sport in the sport of volleyball. One of my undergraduate students, Derek May-Wissa, worked with Volleyball Canada on a survey that showed that 15% of concussions were actually happening in the warm-up when players ran under the net to go get the ball. Volleyball Alberta made a rule change to no longer allow players to run under the net, and that was subsequently instituted by Volleyball Canada at the Youth National Championships last year and will be done so again this year. And that's the largest youth sport competition with over 10,000 volleyball athletes. More recently, Dr. Emery is the lead principal investigator on a pan-Canadian research program funded by the NFL Scientific Advisory Board, collaborating with 17 ICRP researchers at the University of Calgary, 25 researchers from 9 other Canadian universities, sport organizations, educators, and multidisciplinary clinical teams at each site. We will complete a research program entitled SHRED Concussions, or Surveillance in High Schools to Reduce Concussions and Their Consequences. The Pan-Canadian Research Program will enroll 6,000 students participating in high-risk concussion sports in 60 high schools in 5 provinces across Canada and follow them for 3 years. The research will target prevention, detection, diagnosis, prognosis, and management of sport concussion in youth. Diagnosis. Researchers at the University of Calgary are evaluating new tools to diagnose concussion, including novel neuroimaging, robotics, and fluid biomarkers. Prognosis. A multidisciplinary research team is working to identify factors that will predict prolonged recovery following concussion in children to inform targeted treatment strategies that will reduce the consequences of concussion. Dr. Yates leads that program, an ACAP study. Mechanism. There are many innovations across animal and human models that will inform mechanisms of concussion and recovery. Rehabilitation. Our group works collaboratively to identify and optimize the management of concussion. Some of our research that I have led has shown that youth and young adults who were treated with treating the neck and the balance systems were 10 times more likely to get medically cleared to return to sport within an 8-week time period compared to the people that weren't treated. Other examples include evaluation of physical activity and sleep therapies to assist with recovery from concussion. We have a number of different studies looking at combinations of treatment as well. And then I led the research for the systematic review on the effects of rest and treatment that informed the 5th consensus on concussion in sport. We're also working with Alberta Health Services Strategic Clinical Networks with funding through Alberta Health Services and Brain Canada, and Dr. Keith Yates, who leads our integrated concussion research program and is testing the effectiveness of a clinical pathway for pediatric concussion in the emergency department. The pathway includes a novel web portal that families can use to obtain evidence-based information about concussion and track recovery. Other highlights include leading the development of a massive open online course in concussion. I checked on my way here today. We have over 4,200 people registered so far. And we also have a number of our program group that were involved in the 5th International Consensus on Concussion in Sports. I was part of the scientific committee and will be doing so again for the 6th consensus. Dr. Emery and I led 2 of the systematic reviews, and we've been involved in tools that were outputs from the meeting, such as the concussion recognition tool and the SCAP-5.
Thank you, Ms. Schneider. Thank you very much. And now we're going to move over to Dr. Cameron Marshall.
Thank you, Chair. I want to say what an honor and privilege it is to be here today. I would also like to thank the committee for the opportunity to speak with you today on a topic that is both my passion as well as my life's work. My name is Dr. Cameron Marshall. I'm a practicing sports specialist chiropractor from Oakville, Ontario. I'm also a published concussion researcher, executive board member of Brain Injury Canada, and the founder and president of Complete Concussion Management, a network of over 250 specially trained concussion treatment and rehabilitation clinics across Canada. I'm also a former athlete, playing both junior hockey as well as lacrosse for Western University. The very fact that this committee exists speaks well of the Government of Canada's understanding of the importance of concussions as a risk factor for the health and well-being of Canadians. Continuing efforts on part of government officials, coaches, teachers, and healthcare professionals are succeeding in raising awareness about the importance of concussions. Founded more than 5 years ago, Complete Concussion Management is currently the largest single provider of concussion care in Canada. We now see more than twice as many concussions each year than the top 11 pediatric emergency departments combined. Each day, more than 100 Canadians visit one of our partnered clinics for concussion-related issues. This year, CCMI will treat close to 7,000 concussions. And since our care is covered by secondary health insurance, we'll save our provincial healthcare systems $30 million in 2019 alone. We also collect, store, and analyze this data through our secure electronic database system. This Canadian-built universal EMR system, specially designed for concussion care, is currently one of, if not the largest concussion databases in the world, and is currently being used to conduct research with 5 Canadian universities. 71% of the concussion patients we see are under the age of 25, and 57% of these injuries are related to organized sport. Complete Concussion Management currently works with over 300 youth sports organizations across Canada and are the preferred concussion providers for more than 50,000 youth athletes. And yes, there's an app for that too. The Concussion Tracker smartphone application walks a coach or sideline therapist through a brief injury reporting form, instructing them on key things to look for. Once the injury report is complete, notifications are sent to every other sport, team, coach, teacher, and trainer associated with that athlete. Medical clearance letters are scanned by the app and shared with all stakeholders associated with that athlete. Constant and automated communication paired with appropriate documentation and tracking so that nothing falls through the cracks. A few weeks ago, Mr. Paul Hunter from Rugby Canada stated to this panel that if there was an app that could report injuries across sports, that would be an absolute deal maker. The CCMI Concussion Tracker app does exactly this, and we have now made it free for all schools and sports programs in Canada. A few weeks ago, Dr. Roger Zemek reported to the committee that the number of concussions presenting to Ontario physicians' offices and emergency departments has quadrupled in the past 10 years. According to the Ontario Neurotrauma Foundation, the average wait time to see a physician in Ontario is 18 days, 250 days to see a neurologist. These results demonstrate some inherent limitations of our healthcare system to deal with this rapidly growing problem. As such, Complete Concussion Management went about tackling this problem a little differently. We train licensed physiotherapists and chiropractors to be used alongside family physicians for co-management and to improve patient accessibility. Physiotherapists and chiropractors are licensed and regulated healthcare professionals and that have concussion diagnosis and management within their licensed scope of practice. Over the past 7 years, the scientific evidence has pointed towards the use of physical exertion testing as a way of establishing physiologic recovery from concussion and preventing premature return to play. As we now know, it is the repeated concussions that ultimately do the most damage and are the single biggest issue in sports-related concussion. Specially trained physiotherapists and chiropractors have the skills, time, and equipment to run these necessary tests and assist with safe return to sport. As a result, 30% of our patients are now directly referred from family physicians and emergency departments who don't have the equipment or time necessary to run these essential tests. In our experience, the formation of local, collaborative, multidisciplinary networks of trained healthcare professionals supports the provision of a high standard of evidence-based best practices concussion care in both urban and rural areas of Canada. Once again, I'm honored to be able to address you today, and I look forward to answering any questions that you may have so that we can continue to work together to improve concussion care in this country. Thank you.
Thank you, Dr. Marshall. And now we're going to be going to the members for questions and answers. And what I'm going to say is, as you can see, the lights are flashing. We've got about 30 minutes till our vote. I think we're only going to have time for one round, and we're going to start that with Mr. Fisher from the Liberals.
Thank you, Mr. Chair. Thank you both for being here. I suspect you've both been following along. It's been eye-opening and jaw-dropping for us on the committee, and I'm sure probably a lot of it's just been regular data that you're very well aware of. So thank you for being here. Dr. Schneider, I'm thrilled by this program, this online course that you've got. Blown away by the fact that you've got 4,200 people signed up. One of the things I wanted to ask you is, how are you doing your outreach? Will the coach of a Dartmouth Whalers Pee Wee A House League team know about this? How would they find out about it? And would they be welcome?
Yeah, our goal with this massive open online course on concussion, that's a great question. The MOOC our goal is to make it appeal to a broad audience. So everyone's welcome. And we also want different stakeholders because that also facilitates some great discussion. And so our goal is to take the research evidence, a lot of what it's very much aligned with the 5th International Consensus from Berlin, and to take that research evidence and then help disseminate it to the general public, to people that are stakeholders in different areas. We also have a reflective process where they look at, how does this apply to your own area? Do you want to look at developing policy within your local area or your sport organization? And help with tools and reflective documents for that. And then there's also the opportunity to have a discussion online with myself and then Dr. Pierre Fremont, who was here last week. We're co-teaching the course, and Dr. Fremont has done a very successful MOOC in concussion in French. And so he approached our group and said, I think you guys are the right people to adapt this to English, and I think there's a need for it. And so we've had a very, very large interest from multiple different stakeholders. I've been in contact with a lot of different people since we announced it a couple weeks ago.
It's incredible, and the fact that you've got 4,200 really speaks highly of you. I think about my son who turns 18 tomorrow, and I think about his minor hockey career and the fact that I don't think us as parents or the coaches or the managers for the team back in the novice days had any clue about any of this stuff. So I'm very happy that there's been what seems like a steep learning curve for people. I'm wondering about retraining. So as a coach that maybe coached my son in novice, who's still coaching now, has there been along the way, in your opinion, the ability to pick up information on concussions, whether it's diagnosis or whether it's management or whether even the more difficult one, prevention?
Yeah. So I think there's been great interest in the area of concussion. We did see a lot of an increase in reporting after 2011, 2012, when we saw Sidney Crosby have a concussion. And then there's also been a lot more interest in what can we do to prevent them, because I don't want my players to be out, and a lot more concern about doing the right thing and getting back at the right time. So I think there's that desire. One thing that's also, I think, been really helpful for coaches is knowing it's the recognize and remove piece, and then refer to a healthcare professional that can then perform that assessment from a follow-up standpoint. So, and there's been some great initiatives done in the hockey world and many other sports as well to help disseminate that information, which is great. And it really is a team that work together from a sport, science, health. Yeah.
Very encouraging. Dr. Marshall, you talked about your app, and I think it's incredible. You're a business. You're a for-profit business. So tell me about how you've made this app free for schools. Is it, you said schools and sports programs in Canada, so not a minor hockey leagues per se?
Yeah, hockey, soccer, any sport. The app that we originally had was tied.
New, right? The fact that you've made this free is really recent.
Yes, okay. We just did that. It's always been free, but it's been tied to our clinics.
Right.
So we have a clinical network of 250 clinics, and they work with the local sporting group. And so originally, the way that the app worked is that if an injury was reported, it automatically notifies the other sports that person is involved in, because we found that the communication lines were getting dropped. If an injury happens in hockey, the soccer coach doesn't find out about it. And we've heard that concern raised in this committee throughout the process. And so the app that we developed originally was just tied into our clinics, because we had no other way of really, if they go to their family doctor or a different clinic, we don't know what's going on at that point. And just this past year, we've revamped it now to include it, so that if a patient does come into one of our clinics and want to utilize that avenue, the app will communicate with them each step along the way. If they happen to go to a different healthcare provider that may not be within our network, let's say they go to a family physician or a sports medicine physician, that healthcare professional can manage that case. And when the athlete comes back with their clearance letter to return to sport, the coach can then scan a copy of that using the app, and then it shares that letter with every other coach and trainer, so that everyone now has a copy of it. So that everyone knows what's going on with this particular athlete. They can't lie to their coach. They can't sneak on.
That's incredible. So going back to what I asked Dr. Schneider, then how do you do outreach? How do I let the Cole Harbour Wings know about that program and that app is free for them?
We're trying our best to obviously get that message out there.
We'll try to help. If you reach out to our office, we could try to help.
Okay, I will do that. I will do that, yeah.
Thank you, Mr. Chair.
Just a plug for the app. What's the name of the app?
It's called the Concussion Tracker, Complete Concussion Management Concussion Tracker.
Okay.
We use CCMI.
Moving over to the Conservatives now, and Mr. Kitchen. Dr. Kitchen.
Thank you, Mr. Chair, and I'm going to stay on this topic because it's one that's piqued my interest in. And Dr. Marshall, thank you very much for being here today. And my understanding from as you mentioned, a lot of things that we've discussed throughout committee is how do we take the information from one sport and put it to another, and this sounds like we can entail all of that there. And it sounds, because it goes not only from community-based minor hockey, minor soccer, but all the way up to junior levels. And I know you are involved across the country in your organization with junior hockey teams across the country, and in particular one of my own junior hockey team that I was team doctor for many years. So with that said, and putting on my doctor hat, how can you explain to the committee on the issue of privacy? And how that is contained within your app, that we have assurances for and that protection.
Yeah, I mean, privacy is something that we've taken extremely seriously since the genesis of our entire system. And so the way that the app actually works is that we have one file for one athlete. Some of the other technologies that are out there, you might have different setups for different sports, and that's why they don't communicate. So we've done one file for one athlete. And the way that it works is that when they register for our system, they actually get a number. So they're kind of de-identified right from the get-go. And so if a coach goes to add that athlete, they don't know them by name. They have to add their number. And the only way they can get that number is by the athlete handing them that number. So it's almost like a credit card type of transaction. Once the coach adds that athlete actually has to confirm and accept that coach might be able to see some of their information. The only medical information that's passed is what their current injury status is. So we don't know what happened during their medical examination. We don't know what happened even when the injury was reported. The only person that knows that is the person who filed the report. The other coaches will know that there's been a report filed, but they can't actually access that report. So the only thing that's shared, and it's only shared by consent from the athlete, and they can remove that at any time, or their guardian can remove that at any time, is just purely their injury status. So it's either healthy, it's injured and not yet allowed to return to practice, or it's now injured and allowed to return to non-contact practice, and then fully cleared, ready to go.
And this is shared throughout the whole multidisciplinary spectrum of professionals, correct?
Yes.
Okay, great, thank you. One of the things we've talked a lot about is prevention, and how do we take this information, this data collection that we need, which we don't have, to help us with that prevention. And it's great to see that a lot of times in sport, for example, Dr. Schneider, your comment about the volleyball practice, and the reality is that we see a lot, and we see that as well in hockey, with in a lot of head injuries happen to goalies during warm-up and practice time, not during the actual game time. And so just again, both of you quickly, if you could, because I want to let my colleague here ask a quick question, if we can. But that research, is that, you've talked about volleyball, is it going to, will we be able to take that data for hockey as well?
So from a research standpoint, our research group has done a lot of work from a hockey standpoint, looking at prevention and targeted prevention. And we use an injury prevention model where we're first looking at how common are concussions in each sport? What are the risk factors? And we partner with a lot of the stakeholders in sport to say, well, what do you think increases the risk? Let's measure it. And then we can actually measure those risk factors and then look to see what the biggest risk factors are and target prevention strategies so that we can then have the biggest public health impact. And that's where a lot of the work around the body checking research has come from, and looking at, well, if we can decrease risk of concussion by 70%, that's a big public health savings. So similarly, we've done work in soccer, work in volleyball, work in multiple different sports. So certainly that model, I think, would work well across sport, and that SHRED program will be doing that in the schools.
Thank you. Dr. Marshall, any quick comment on?
I mean, she is the prevention expert. I think the University of Calgary has kind of been the pioneers in this field. Where we might be able to help is just purely on tracking pre-intervention versus post-intervention, and actually being able to have measurable change with some of the interventions that they might put in.
Thank you. Doctor, I'm going to allow my colleague to just ask one quick question.
Yep.
What's that? 2 minutes?
About 2 minutes, yeah.
Go ahead.
Okay. All right. Well, thank you.
Yeah.
Of course, NP Fisher asked most of my questions to you, Dr. Schneider, regarding this online course. I guess one thing I would like to know about that is there's some type of a certification, a certificate you get at the end of this,
Yes.
this completion of this course. Do you see this hopefully being a mandatory requirement for coaches in the future to take these types of courses in order to be more aware of concussions and how to deal with it?
That's a great question. So there is an option to have a certificate, but there's a nominal administrative fee. Everything else about the course is free, but there's a nominal fee for the certification of completion, and there is an evaluation component they have to complete so that we know that they've actually covered the material. But there are also other courses, the Concussion Awareness and Training Tool that gives you a certificate. It's a shorter duration, but then that can automatically go to specific organizations, and it's meant for different professionals in different areas. And then the Coaching Association of Canada also has the Making Headway program. So we actually cover all these different pieces within the MOOC, so people are aware of them. So I think depending on the needs of the individual, there's capacity to look at some of these different training modules in different environments.
Excellent. And how do you reach out to to the community to let them know about this online course? What have you been doing?
Well, we did one media release, and it's gone apparently internationally. I've had lots of people contact me from overseas saying they've heard about it. So it's really spread like wildfire, and we have the registration portal on our homepage at the University of Calgary Faculty of Kinesiology. And so we haven't done a lot of hard marketing about it yet, but we're open to have whoever wants to participate join in.
I guess it's open internationally too. It's not just, if it's online, anybody can tap into it, correct?
Yeah, and we have international collaborators contributing too.
Thank you. Now we're going to be moving over to the NDP and Ms. Hardcastle.
Thank you very much, Mr. Chair. Hopefully I'll get to ask both of you doctors, but what I'd like to start off with, Dr. Schneider, is the issue of diagnosis of concussion. It's a sensitive issue. There needs to be so many factors that are considered, and there's got to be a lot more research that is done. And I don't know if you can explain to us where you think the most immediate challenges are, or hurdles that we can breakthroughs that we need to get to for understanding the issue of diagnosis.
I think that's a great question. And unfortunately, I don't think there's a really simple answer to it, which makes it a challenging area. So it's very much a clinical diagnosis based on a trauma, then followed by the onset of symptoms and clinical findings. And typically there's no findings on any type of neuroimaging. A lot of the research work that we're doing is looking at, because there's so many different areas that can be affected from a concussion, we want to look at them all together. So we have people with expertise in multiple different areas all working together. And we just finished a 5-year cohort study with just over 3,000 youth ice hockey players, where we looked at a bunch of different tests in different areas, looking at cognition, looking at balance, looking at dizziness, looking at neck involvement, looking at some of the mood and other factors, and how do those actually associate with one another. So we're actually in the process of analyzing some of that data right now, and the SHRED concussions will build on that more, where there's also neuroimaging, biomarkers, robotics. So there's going to be even greater depth so that we can help better understand what we're actually seeing following concussion, to better measure it, that can then help inform that diagnosis piece. So I think the literature's really evolved over the last few years and is continuing to do so. But because there's so many different components different areas of the body that can be affected from a concussion, it's certainly an ongoing process that we need to further evaluate.
So we don't have any set effective methods right now. We're still trying to achieve that.
There's no one test. Yeah.
Okay.
There's no one test, but there's
what is your impression on that, Dr. Marshall? Sorry to cut you off. I'm just trying to get an idea of where we should be going, or how we should be approaching this view in this study, knowing what we know about diagnoses. And what do we know? So this is your chance to say that on the record so that nothing is assumed.
Just like Dr. Schneider said, it is very much a clinical diagnosis. We don't have any objective testing for concussion that can definitively, there's no gold standard. So if you look at, surgery, for example, for knee injuries, that would be the gold standard. Actually go in and see that a ligament is torn. You can confirm that as a diagnosis, but there's no way right now to confirm that a concussion has happened. So we don't have a gold standard. So it's very much a clinical diagnosis where the injury has occurred. There was some sort of mechanism of injury followed shortly thereafter by the onset of symptoms. There are tests that are out there, like Dr. Schneider said. Any one test used in isolation is not helpful. However, combining them into a battery of tests, if you will, can add some insight into the picture. However, there are some challenges with that still.
You got it, 3 minutes.
Okay. And so the evidence that you are gathering now, the data that each of you, I'll give you each a chance to respond. The data that you're each gathering then, are you noticing that now? I think we're noticing as we're doing the study that there are some really exemplary and vanguard leaders in this area. And do you all know that each other exists and is collecting this data? How do you think we could help with that? We heard, I'll give you just an example. We heard earlier in a testimony from Eric Lindros that there should be a brain bank and there should be some kind of a knowledge bank or one place. Tell me what you think, what your impression would be.
You want me to? You want to go?
I think there's an opportunity. From a Canadian standpoint, we have a lot of people that are doing a lot of leading edge work and that all work together across the country very collaboratively. And it's very unique internationally. At the last consensus, people actually would come up to the mic and said, I'm not from Canada, but I have a cousin there. So like there was a really strong Canadian presence, like pan-Canadian, which was extremely exciting. And I think speaks to the large number of people that are doing a lot of leading work in this area. And then we have a very collaborative network called the Canadian Traumatic Brain Injury Research Consortium, or CTRC, where everyone does do a lot of work together. And we're also, from a research standpoint, we published recently some different guidelines around concussion in terms of what we should be collecting, so we can then all pool that information together. So I think there's a lot of efforts to work together collaboratively. And ultimately that's, I think the more we can all work together in a team, getting all the different perspectives, ultimately that's how we're going to be able to answer some of these questions in the best way.
Dr. Marshall, do you see an opportunity for government role in that?
I don't know if it's necessarily a government role. I think other than potentially some funding towards some initiatives like that. The way that we see our role in that is purely we try to take the evidence that the researchers do and try to put that into practice, while at the same time collecting that information to see how well it actually works in the real world, and then with that data partnering with universities like the University of Calgary, who we're not partnered with, but we can talk after. But we've done a bunch of research with U of T, McMaster, University of Ottawa, Carleton, just in using the data that we have. It's such a wealth of knowledge, and it's not really replicable anywhere. And that's where I see kind of our role, at least in that, is kind of trying to collaborate with the universities while we're on the front lines collecting kind of data from the rural and urban areas.
Thank you. And we're going to move over to the Liberals with Dr. Eyolfson. And Dr. Eyolfson, you'll have about 3 minutes, and then we're going to have to run up for a vote.
All right. Thank you, Mr. Chair. Thank you both for coming. Now, we talked about prevention. Dr. Schneider, you were talking about certain rules that have changed that, like you pointed out, no running under the net in volleyball, and changing the ages that, you can body check in hockey, these sorts of things. There's been some controversy about certain sports that should be avoided entirely below certain ages. In your experience, are there any sports that you should say that people below a certain age should not engage in?
That's an interesting question.
Just for example, just pulling a sport out of the air, like for instance, football.
Yeah.
Tackle football. Would you say there's an age that someone below a certain below that age should not engage in, should not start it until past a certain age?
Yeah, I think there's a lot more research that needs to be done to really understand some of the risks in different sports at different ages. One thing that we have seen in some of the hockey work that our group has done over the last number of years is that we actually do see a spike in risk of concussion at that 11 and 12-year-old age group. So rates of concussion would be very high, almost similar to that of what you'd see at a professional level. And then that rate comes back down again. So potentially that's a vulnerable age for those kids then. And ultimately, we do see that decrease in risk in terms of absolutely not playing. I think that's an interesting question, but it would be interesting to look at some of the different rules and around risk. And I know there's a lot of sports doing some evaluation to look at that and around tackling and limiting contact practices. And there's evaluation going on to look at some of those. So it'll be interesting to see what some of that research shows.
Okay, thank you. And we also talk about equipment. And I know there are people sometimes take a very simplistic view of protective equipment, particularly helmets, and we know that helmets are not the panacea to completely prevent head injuries. But have you, in addition to restrictions and rules of play, have you been able to make any recommendations in changes in the types of equipment or standards of equipment used, protective equipment in different sports?
So that's another really good question. We often look at prevention from rules of the game, equipment, and then also from an intrinsic risk factor, or factors that change risk that are internal to that person. So some of the intrinsic risk factors would be related to their awareness in space, coordination, head-on neck control, that kind of thing. Then, of course, the equipment and then rules of the game. So we do some evaluation in that area. There's been some work done in the area of looking at mouth guards and risk in youth ice hockey, and our systematic review from Berlin showed potentially a non-significant protective risk of about 19%, with the need for further research. So we've actually been able to compare that because in Alberta, because of the lack of literature, there wasn't necessarily rule enforcement around wearing of mouth guards. So within our youth concussion studies, we've been able to study the kids that have and have not worn mouth guards. So you can stay tuned for the results
Thank
of
you.
that.
And I want to thank, on behalf of the committee, Dr. Schneider, Dr. Marshall for being with us. We apologize that we need to suspend to go up and vote. Any other, beyond your testimony, any reports, anything you would like to provide with our analysts so that would inform our report? Report should be done by the end of spring. It will be tabled in the House of Commons. Thank you very much. We're going to suspend right now. Thank you.
Thank you.
This is the Subcommittee on Sports-Related Concussions in Canada and of the Standing Committee on Health. And for our second round of witnesses today, we have from Concussion North, Dr. Shannon Bauman, Medical Director, Lead Physician. She's coming to us via video conference from Barrie, Ontario. Welcome, Dr. Bauman. And from Hockey Canada, we have Dr. Mark Aubry, Chief Medical Officer, as well as from Hockey Canada, Todd Jackson, Director of Insurance and Risk Management. We are going to start in terms of statements by Dr. Bauman, just in case we lose the video feed. You can hear us all right, Dr. Bauman?
Yes, thank you.
Okay, and this is your opportunity now to make a statement.
Thank you, Mr. Chair. Respected members of the House, I'm honored to be here with you this evening. Thank you for the invitation to be here as a witness. I want to thank the committee and subcommittee for giving attention to such an important topic. I will start by briefly introducing myself. My name is Dr. Shannon Bauman. I'm a primary care sports medicine physician and have a dedicated practice to the care of athletes of all ages and all ranges of participation, from recreational level to those of professional athletes. I've been a team physician for lacrosse, hockey, and sledge hockey. I currently hold medical privileges within the Department of Family Medicine and Department of Surgery at the Royal Victoria Regional Healthcare Centre in Barrie, Ontario, and am associated with the University of Toronto. I'm the medical director and founder of Concussion North, a physician-led interdisciplinary team dedicated to the medical management and rehabilitation of sports and exercise-related concussions. Concussion North has been recognized as a world leader in the management of concussions, and I've been asked to present on our model and our research in the recovery of sports-related concussions at various meetings such as Berlin, Croatia, and across the United States. We see Olympic athletes, world junior hockey players, professional athletes, as well as local athletes and those who travel far distances across Canada and the United States to receive care at our clinic. Most recently, Concussion North has been recognized provincially as a Minister Medal Honor Roll for our dedication to excellence in concussion care in Ontario. I'm proud to be an expert advisor and committee member to Parachute Canada, Ontario Neurotrauma Foundation, the Canadian Concussion Collaborative, and MOMS team working with the NCAA and U.S. Department of Defense. Through my work on these committees, I've also co-authored 5 of our leading provincial and federal guidelines on concussion, including the Canadian Guideline on Concussion in Sport, our Statement on Concussion Baseline in Canada, and Ontario Neurotrauma Foundation's Standards for Provincial Care. First and foremost, I'm a clinician that provides care to my patients in the focused area of sports-related concussions. I'm also a clinician scientist. My area of research is in the management of concussions within an interdisciplinary team model, the recovery of sports-related concussions, and factors contributing to the risk of prolonged recovery, and sex differences in the recovery of concussion. Based on my professional experience in concussions, I have 2 primary recommendations that can inform this subcommittee's work. The first is national uptake and implementation of the best practice guidelines. Through the leadership of our federal government and the Public Health Agency of Canada, as well as the work of our nationally recognized researchers, expert clinicians, knowledge translation specialists, in Parachute Canada and the Ontario Neurotrauma Foundation, we've produced strong guidelines that set a high standard of care for concussions both provincially and nationally. Working with the majority of Canada's national sports organizations, these guidelines have now been translated into harmonized sports-specific concussion protocols that allow all sports stakeholders to work together to optimize the recognition and management of concussion in Canada. However, we need all healthcare professional organizations, provincial and municipal sports organizations, as well as school divisions to widely adopt these protocols to ensure the messaging is consistent across all school and sports settings. This isn't happening currently across all provinces in Canada, and we are often confronted by mixed messages that sport and school stakeholders are receiving from other sources outside of our guidelines. Second, we need government to fund and support physician-led interdisciplinary concussion centers of excellence across Canada. These centers need to be geographically located and funded appropriately to ensure everyone has access to interdisciplinary expertise needed to successfully treat concussions. We know that most individuals recover from concussions within 2 weeks of injury, But for those 25% of individuals who continue to experience prolonged symptoms, finding clinics that uphold the current stated standard of care for persistent symptoms is a challenge. Our federal guidelines are clear in stating that people suffering a concussion require assessment by a physician, and some may require a multidisciplinary clinic with a physician with extra experience in concussion care, together with an interdisciplinary team of healthcare professionals. Caring for athletes and patients with persistent symptoms of concussion is challenging. As a physician, my licensing and training enables me to assess the complex medical issues, including migraine, sleep, cognitive difficulties, depression, exacerbation of other coexisting medical conditions that all need to be recognized by the physician providing an initial assessment. Only physicians can provide this type of care, and these conditions such as concussion are becoming more common that we see these. There are also aspects that will require rehabilitation by allied healthcare professionals with experience in managing the nuances of this injury, which may include physiotherapy, athletic therapy, occupational therapy, neuropsychology, and optometry, all of which exist in clinics under one roof. Unfortunately, we need to be wary of large concussion businesses that are falsely promoting expertise and are falling short of providing the necessary standard of care that we see in our guidelines. Despite marketing or certification of concussion expertise, it's a challenge when these clinics are not meeting our current guidelines. Like conditions like cancer that are medically complex, concussion care requires physicians, in addition to other allied healthcare professionals, working collaboratively in an interdisciplinary fashion. In short, we need to establish regional centers of excellence that are able to uphold a high standard of multidisciplinary care set out by our guidelines. We currently do this at Concussion North, and I'm quite confident that with federal support and funding, we'll be able to offer this high standard of care in centers across Canada. Thank you very much, and I look forward to your questions.
And thank you, Dr. Bauman. And that we'll move now over to Hockey Canada and Dr. Aubry.
Mr. Chair and members of the subcommittee, thank you very much for inviting Todd and I to give you a report. I'd like to take the opportunity to introduce myself before the committee. I am a sport medicine physician who is the co-director of the Ottawa Sport Medicine Centre. We see athletes with concussions on a daily basis. I'm also the Chief Medical Officer of Hockey Canada and the International Ice Hockey Federation. And I've been involved in the world of concussion for the last 20 years, having treated numerous professional and amateur athletes with this terrible injury. The International Ice Hockey Federation, in cooperation with other international groups such as the IOC, FIFA, World Rugby, and now the FEI, the Fédération Équestre Internationale, has organized 5 international symposia on concussion in sport, with the resultant consensus on concussion, which has appeared in medical journals and provides the guidelines on issues surrounding concussion based on scientific evidence. The last symposium was held in Berlin in 2016, and we are now preparing for the 2020 6th International Symposium in Paris. The symposium brings together the worldwide experts on concussion, and following a 2-day symposium, an expert panel develops a consensus on the evidence presented during those 2 days and publishes the guidelines in those medical journals. In conjunction with the symposia, we've also developed a sport concussion assessment tool, now called the SCAT-5, the Child Sport Concussion Assessment Tool, the Child SCAT-5, and the Concussion Recognition Tool, CRT-5, for non-medical people who are involved in sport. And these tools have been translated in several languages, including French, with the help of Hockey Canada and other experts across the country. I would like to speak briefly on the work of Hockey Canada, who has worked diligently for the many years on the issue of concussion in their sport. And I'm joined by Todd Jackson, who is the Director of Insurance and Risk Management of Hockey Canada, and he has directed the safety program for many years, and he certainly gave you a lot of the details on the different programs that Hockey Canada has for concussion. Since the late 1990s, Hockey Canada has produced player safety information through the Hockey Canada Safety Program. They have delivered in-person and online training sessions, and they've worked with their provincial members to provide tools to all stakeholders to make the game safer. These tools include an online resource center, a concussion app, and an online educational stream for coaches, trainers, parents, and administrators, all in the name of player safety. In 2011, Hockey Canada introduced the zero-tolerance head contact rule. Minor penalties, double minor, and major penalties are now assessed for any head contact, including incidental head contact. And in 2013, the rules and regulations were changed to remove body checking from the game for kids aged 12 and under. Today, approximately 85% of games played under the Hockey Canada umbrella are played without body checking. Hockey Canada, through its members, delivers information to coaches and parents using an online educational platform called Respect in Sport, which deals with many topics, including concussion awareness. Education and skill development are also provided to players as they go through the system to improve their ability to keep themselves and their opponents safe during play. Among the many safety measures, Hockey Canada calls for a safety person to be present for all minor hockey teams across the country. The safety person is educated to recognize all types of injuries, including the signs and symptoms of concussions. It also has a strict concussion protocol in place, which calls for the removal of any player who shows signs and symptoms of a suspected concussion. The established return to play protocol has a series of steps in place, including medical clearance from a physician to ensure that they no longer have any symptoms and that the athlete is safe to return to play. Hockey Canada continues to work in partnership with the Sport Injury Prevention Research Centre at the University of Calgary, and you heard from Dr. Catherine Schneider. Through their research, the centre has provided much of the evidence on the issues surrounding concussion, and Hockey Canada has used that research to guide their injury prevention efforts, including applicable rules and regulations. Finally, we feel that it is crucial to have an active and healthy society. For this, we need families to feel safe to have their children participate in sport. We also feel that we need to have ongoing education and continued research on the issue of athlete safety, which does include concussion safety. Thank you.
Aubrey, Mr. Jackson.
I just, the statement was a statement that we put together in conjunction with each other. I'd just add that I think that the networking that we have done has been crucial, and certainly the Sport Injury Prevention Research Centre is an example of that. Parachute Canada is another example of that, and that has led to the effective tools and the ongoing information that we've received to help us make important decisions around safety internally as an organization.
Thank you. Now we're going to have an opportunity to hear some questions from our members that you'll have an opportunity to answer, and we're going to start with the Liberals and Dr. Eolfsen.
All right. Thank you, Mr. Chair. Thank you all for coming and giving your testimony. Dr. Bauman, I'm an emergency physician myself, and so I understand the challenges of knowledge translation to primary care providers. Now, guidelines of all sorts, of all treatments, change from time to time, and there's always efforts to get that out there. And some issues, it's often a challenge to get things into the curriculum, even at the medical school level. Are you involved in getting training out to physicians at the early levels of training so that they have consistent knowledge of how to apply these assessment guidelines?
Thank you for your question. Yes, I've been involved with some work through Parachute Canada, where we've created an online platform for education that has received medical education credits designed for family physicians and pediatricians, as well as medical students. It is a rolled out course that we were able to prepare that I helped assist with. I think when we have information like this that's coming out, it's great to have that get to the physicians and put these tools in their hand. Tools developed by physicians for physicians and for other healthcare practitioners, I think, are really essential. I've also been involved at local levels with giving presentations to family physicians, and I teach medical residents through the University of Toronto. We have a Department of Family Medicine program here in Barrie, Ontario, where they come through our clinic and work with me firsthand seeing patients. I feel that if we can get the information into the generation of new family physicians and residents and medical students, we will have a ability within our capacities as family physicians to initially assess concussions as they come in the office, and also a better understanding of the guidelines that are out, because it's our opportunity to practice these guidelines in our clinical world.
Okay, great. Thank you. Now, have you been approaching the colleges to actually put this as part of mandatory parts of the curriculum, like the Canadian College of Family Physicians or the Royal College of Physicians and Surgeons? Has there been dialogue with them to include that in the actual standardized curriculum for residents?
I know some of my predecessors who've spoken to the committee previously, like Dr. Pierre Fremont, Dr. Charles Tatter, are individuals that have been spearheading some of these different aspects within the medical school. I haven't directly been involved with the medical schools myself, but I know there are some great leaders in the field that are working on those efforts that you guys have heard from previously.
All right, thank you. Dr. Bauman, I'm going to, Dr. Aubrey. I want to switch gears here. And Mr. Jackson, you might be able to help me out with this. Now, one of the issues that's come up, and we heard some testimony about this, is the issue of fighting in hockey. We know that it's against the rules at all levels. It's absolutely forbidden and not tolerated at all at the junior levels. But certainly at the professional level, particularly in the National Hockey League, although against the rules, it is, depending on who you talk to, either tolerated or, if you listen to certain sportscasters with loud shirts, encouraged.
No idea.
Yeah, exactly. Yeah. So has Hockey Canada taken any stance to aggressively message the NHL to say, I don't care what the ratings, what would happen to your ratings, you need to get the fighting out of professional hockey?
So I think, first of all, from a minor hockey perspective, I think Hockey Canada's role is certainly minor hockey. I'm not sure it's up to Hockey Canada to tell the NHL what it should do or shouldn't do. I do feel strongly, though, that fighting should not be allowed, and certainly we've provided not only that message to Hockey Canada, but certainly across all levels of our sport. I think that the NHL has certainly changed tremendously. I think the fighting is down considerably, and I think eventually will probably just sort of wear itself out. And I think that a lot of pressure has been brought by not only members of the hockey community, but also from the media. And I think they've heard the message loud and clear, and I think it's changing. We had a summit at the Mayo Clinic involving experts from around North America, and certainly one of the published statements that came out from the summit, which was published, is certainly to abolish fighting at all levels of hockey. Todd, you want to add to that?
And I think that the role from Hockey Canada's standpoint is to make sure that we are influencing our culture, so our culture in the amateur level, to the fact, just what you said, fighting is against the rules. We don't want to see fighting, and it's not tolerated. And if we can start to influence that right when the kids are at a young age, all the way up through the levels, then we are going to reduce and bring down the amount of fighting at the amateur level in the amateur hockey game.
Yeah. Okay.
I'll be moving over to the Conservatives and Dr. Kitchen for
Thank
7
you,
minutes.
Mr. Chair, and thank you all for being here today. We greatly appreciate it and tolerating with our little interruptions that we had beforehand. So I appreciate you staying here. Dr. Bauman, and I missed a little bit at the beginning. Your credentials are you're a family physician and a specialist in sports injuries. Is that correct? Or
I'm a family physician with a diploma in sports medicine through our Canadian Academy of Sports Medicine.
okay, thank you. And you've been involved with the Parachute organization. I understand, correct?
Yes, I'm one of their expert advisors on their various subcommittees.
Okay, and so you did a specialized training after medical school in a diploma program, correct? Through.
I did family medicine through Queen's University, and then I did a fellowship in sports medicine through McMaster University, and then I received additional certificate of competency through Canadian Academy of Sports Medicine for sports medicine practice, and I have a dedicated practice to sports injuries for the past 12 years.
Right, and I appreciate that because that's where I'm leading to now. So you're a clinician, and I'm a hockey parent, hockey coach, etc., and being involved in the sport for many, many years. And and I won't tell you how long, but it was 76 was when I got my coaching certification, but we won't go that far. So anyway, my question to you is, let's say my son has an injury. My daughter has a concussion that I believe. And I heard about your credentials and I'm going to come see you. Walk me through how that would work.
Okay. So your daughter has a concussion. There's probably already have been someone on the ice with your daughter who's identified a possible concussion. That person's job is to recognize and remove your daughter from play. Now that person, depending on the severity of the symptom she has, meaning if there's any red flags that there's a cervical spine injury or some neurologic signs, it may be recommended that they go to the emergency department for immediate assessment, or that person seems stable and the recommendation would be to follow up with their family physician. Ideally, that they should see a physician, whether it's through the emergency room, family physician, walk-in clinic, urgent care, within probably about 48 hours. At that point, there will be a medical assessment conducted by that physician, either determining if there's been a diagnosis of concussion, ruling out some of the medical red flags, determining if there's any imaging that needs to be ordered, and given some early education and recommendations about how to manage the initial signs of concussion and symptoms, how to gradually be reintroduced to school, how to go about their day, and some guidance to how they're going to gradually become active. There should be an additional follow-up after this point. So this could be the role of a primary care physician. And luckily with most concussions, 80% of patients are going to only need care under their primary care physician. There'll be a follow-up within about 2 weeks where that physician can then see how the transition of returning to school, day-to-day, how the symptoms are recovering. If the physician at this 2-week appointment identifies there's something that's making it difficult for your daughter to continue to learn in school. They're having some visual symptoms, they're having headaches, they're having difficulty with learning, they're getting worse during a school day. Something like that may suggest that that physician will make a referral to a specialist such as myself, who's had additional experience in concussion care. It could be a primary care sports medicine physician, a pediatrician, a physiatrist, a neurosurgeon, or a neurologist. So that physician's role is to make a referral directly to a physician who can do some further medical assessments, pick up some of those subtle nuances that may end up giving your daughter a prolonged recovery. And that would be the role that I play. I see patients every day in my clinic.
We've got to that stage with my daughter, and I've been referred to you, your clinic specifically.
Okay.
When my daughter comes in that door, who's seeing her right off the bat?
That would be me. So
you would see that person right off the bat. There wouldn't be any other referrals, no other assessments beforehand by anyone.
That would be me.
In your
the family
clinic.
Physician. Yep, I'm referred by another physician. That person directly comes to me. So my job is to spend about an hour with your daughter to an hour and a half. I do a very detailed history, medical assessment, examination, and we discuss some of the features that we've identified of her concussion, which could be sleep issues, migraine, could be visual issues, vestibular issues, could be mood exacerbations, could be things, but this is all individualized. Depending what I see within my team under my roof, I have an occupational therapist with a PhD in cognitive rehab. Then I'm referring to her care, and she's going to do a more detailed school assessment and provide some of that education. I also have an athletic therapist in my clinic who will help with some of that exercise piece if I feel that we need to put your daughter through some treadmill testing, some of our testing that we can do in-house under a supervised program. I have physical therapists in my clinic who work with neck and jaw and have competency-based training in vestibular rehab. If that's what's needed, I can refer to that individual. The thing that's different and unique about our clinic is this is a medically supervised clinic. I am there first and foremost seeing your daughter. I will also be overseeing the rehabilitation under my center, and I will also be the one clearing your daughter back to sport, making decisions back to school, and providing the documentation they need when those decisions are made. So the difference in our clinic is that I would be seeing your daughter all the way through, and I would be the one ultimately discharging them and communicating back with the physician that referred everything that's been done for your daughter.
Now, I come from rural Saskatchewan, and we don't have access to that. We don't have access. In fact, we have doctors who come from countries that don't even know what hockey is. And it's not just in rural Saskatchewan, it's throughout rural Canada where we have that access. And it's a big challenge when we don't have those people who have those skills. And there are other professions out there that do have those skills and have done the postgraduate training to provide those skills and that information. And so we need to look at that aspect of how it is for all of Canada. Not everyone is just in the central part of the big cities, Barrie, or wherever it may be. And what would you say for those rural areas?
Dr. Kitchen, we're going to have to hold that for maybe your next round. We're moving over to the NDP and Ms. Hardcastle.
Thank you very much, Mr. Chair. Welcome. Thank you very much for contributing to our report and ultimately recommendations. So I'm making that clear because previously when I asked a question of one of the witnesses, they didn't really understand the link when I said, what should the government's role be? They shouldn't have any. Well, I'd like to see us have something articulated in a recommendation as necessary. So that's the reason for my questions. And I guess I'd like to start with you, Dr. Bauman, with regards to your expertise that contributed to the parachute guidelines and your role with, is it Concussion North?
Yes.
Okay. So does Concussion North apply all of the parachute guidelines?
Yes, we do.
And is the way that the parachute guidelines, the way that they're designed, are they designed, I don't want to say designed, I don't think, but right now, are they in anticipation of what my colleague, Dr. Kitchen, was just mentioning, the geographic realities and the availability of doctors? How realistic are these guidelines right now?
Thank you for your question. When we look at guidelines and the ones we've created through Parachute Canada, we are setting a gold standard of what we want the care to be in Canada. We are looking at what best practice is. We are looking at what needs to happen to provide care so each person, my daughter, your son, has access to the best care that we know. Our guidelines have been an example of what we feel is the best care available. Just because we don't meet that across all regions right now doesn't mean that we shouldn't achieve a high standard of care. For example, if you got a knee injury and you sprained your knee and you needed an MRI, an X-ray wouldn't cut it. If you need that MRI, you could see your family physician, have a medical assessment, and be referred to a place where you get the test you need. Just because we have access to X-rays doesn't necessarily mean that's the best test out there. What I'm saying is we need government support, and my recommendation is that with government support, provincial support, we have the ability to uphold these guidelines, but we need the support financially to do so. I believe, like cancer care, it's a complex medical issue that has a physician with an interdisciplinary team of professionals working together. We don't have a cancer care regional center in every city, but what we do have is frontline physicians like primary care physicians, emergency room physicians that can do a lot of the initial assessments. 80% of people will be managed by their primary care physician or a physician. When we do need referral to a specialty clinic, we're talking about 25% of these high-risk persistent symptom patients. Just like cancer care, we should have regional clinics that we can identify that are accessible to all depending on the geographic area. So I truly believe this is achievable. Clinics such as mine, Concussion North in Barrie, Ontario, Pan Am Clinic in Manitoba, clinics in Ottawa under Dr. Sean Marshall, clinics out in Calgary. We already have some great examples of people doing this work and following what we've set out in our parachute guidelines and our Ontario Neurotrauma Foundation provincial standards in Ontario. We need more examples of this, but we also need the funding to be able to do this. With funding, I believe we can be successful. I'm happy to help with this and show government how to do this if asked.
Thank you. And Dr. Aubrey, I know that your involvement, I think it's 22 years with the Rough Riders. Can you tell us a little bit of how you have seen our approach to concussion evolve and what you think some of the milestones or the best practices that were set up were and how we should be moving forward?
So concussion knowledge has changed our course of action over the last 20 years. And I can actually go back to 2001 when we published the first consensus. And it really wasn't until 2012 where the consensus actually said that we could return athletes back to play in the same game if they didn't have symptoms. And I think now we're all in the agreement that concussion is a serious problem. It is a serious injury. And any suspicion, we need to remove the player from play and then go through a stepwise protocol and process to get him back. And I can say, even speaking in terms of professional athletes, which includes the CFL and the NHL, we have seen that approach, removing players from play even on suspicion, not having them go back until they've gone through the stepwise process. And I think that if we look at the CFL and if we look at the NHL, I'm speaking for professional athletes, certainly the time frame where we've allowed them to go back and play has increased, just because now we're more concerned with safety than actually allowing players to go back, certainly with the risk of getting another concussion or with endangering certainly their health. So I think it's changing. I think it's going to continue to change. And I think just referring back to what the guidelines and where people are in different parts of the country, the consensus actually provides very simple guidelines and can be enacted from all medical people in different parts of the country. And it's really pretty simple. I think the biggest thing is we want them removed from play. We want them rested, but not rested in a sense that they have to sort of not do anything. We allow them to do daily activities. The stepwise process, educating them on symptoms, and certainly not going back until they are free from symptom. And from our perspective in hockey, and certainly from the professional, they get the clearance from their physician.
Thank you. And now we're back over to the Liberals and Mr. Fisher.
Thank you, Mr. Chair. Do I have 7 minutes?
You do.
Okay, thank you. If you could stop me at 5, I'd like to give, as a common courtesy, I'd like to give the last 2 minutes to Mr. Nathaniel Erskine-Smith. Thank you. Thank you all very much for being here, and I apologize for the fact that we did have to step out and we're going to have a shortened time frame here, so I'm not going to get to ask you all of the things I want to ask you. But one of the preeminent concussion advocates is Ken Dryden. We had him here at our committee. And he has said, and I'm going to quote, "We need only to penalize all hits to the head because whether a blow is from a stick, an elbow, a shoulder, or a fist, whether it's done intentionally or accidentally, whether it's legal or illegal, the brain doesn't distinguish, the damage is the same." Now, that was his personal plea to the NHL and to Gary Bettman. I know that Hockey Canada does not speak to the NHL or the NHL Players Association in that way, but you have zero tolerance. Now, I don't know if zero tolerance speaks exactly to what Ken said there. I'm a father of a starting tonight, his first game ever, junior B hockey player. I know that and you can get a kid in Pee Wee who's 6'1" and a kid in Pee Wee who's 4'11", and you got a headshot when that 6-foot guy hits the 4'11" guy, regardless of whether there was intent or not. That's fine. That's not a terrible rule. Zero tolerance is a good thing. Does it speak to the things that Ken wants it to speak to? And do you envision in the future zero tolerance at the minor hockey level through Hockey Canada organizations, filtering up to the NHL level where we will one day see what Ken wanted to see?
Thank you very much for your comment, and I completely agree with you. And I think what's happening now is we're seeing the results in what Hockey Canada and certainly a lot of the other minor sports have done in terms of not tolerating any head hits. When Ken speaks about no tolerance for any head hit, that is the Hockey Canada position. It is clear, even if it is incidental and accidental, it is still not acceptable and it is penalized. And certainly I see that filtering up even to the not only the junior leagues but the NHL. I think if all of us certainly watch professional hockey, and I think what has happened now is most of the hits to the head now, even in the NHL, are not tolerated and are even penalized. And as certainly you can see from two of the last hits that we had over the last few weeks from our star players, even they were penalized for non-intentional hits to the head. And certainly I think the message is clear. And I think what we're seeing is certainly a change in the way not only we look at things, but certainly at the professional level.
Am I good for another minute? Dr. Bowman, you talked about uptake of best practices. You said all healthcare, school divisions, and sports groups need to get that uptake of best practices. You said it's not happening, and you said there are mixed messages, and then you moved on to something else. Could you maybe just give me a minute on your thoughts of how you can get that best practices and increase the uptake?
Yeah, thank you for your question. Guidelines such as our parachute guidelines were done in conjunction with the federal government and our Public Health Agency of Canada. We developed a really strong guideline. The challenge I see as a clinician is I have young athletes coming in my clinic every day from various sporting organizations in our local different leagues across Ontario, and many of them have never seen our parachute guidelines. It's a very strong, well-documented guideline. We've been using it with some of our national sports organizations. My challenge is when I present this to the patient, I would like them to be able to take it to their sporting organizations across our province, locally, in Barrie. This isn't happening. So what I would like to see is that these guidelines we develop with federal funding get support at the provincial level, but that trickles to, for example, in Barrie, our Barrie Minor Hockey Association. I would like them to use it. If we have one guideline that's supported across all of Canada and every organization has access, this has medical assessment forms in it, medical clearance forms. It has a protocol that is a very good protocol for coaches and parents. It includes education, of preseason education. It outlines what to do when your son or daughter has a concussion, who they need to see at various steps of their injury, when they should be referred to a multidisciplinary concussion center. If we had this and everyone was using the same form, we wouldn't have confusion. What's happening is individual clinics are developing their own guidelines. They're developing statements. Then these organizations don't know which ones to use. And unfortunately, our federally funded one isn't getting in the hands of the athletes that need it. I've been fortunate enough in Oro Medonte to use the guideline developed by Parachute Canada.
Appreciate
you.
that. We're going to move over to Mr. Erskine-Smith for about a minute and a half, 2 minutes.
Thanks very much. Just following up on that, is there a province, I understand with the federal guidelines as they are, and you mentioned there's sort of a gold standard co-developed with PHAC. Is there a province that we can hold out as the best practice for implementing these guidelines?
I really do feel that Manitoba and the work with Dr. Mike Ellis, who's one of our co-directors on the Canadian guidelines, has been doing instrumental work within Manitoba. They have a federally funded clinic, and I think that's important to note. When you have a physician with expertise together with a clinic that's received federal support and funding, they've been able to utilize their clinic as a means to get provincial organizations on board. They've been working with some of the First Nations communities. They've been able to get full support. When you have that kind of clinic example, which is why I say a federally funded multidisciplinary clinic needs to be supported, I believe we could have better uptake with our guidelines, provincially and federally.
Thanks very much. And very briefly,
Thank you,
I'm
Mr.
out
Erskine-Smith.
a minute. Oh, okay.
Yeah.
All right, thanks.
We are going to move to our second round. We've only got about 2 minutes in this round for each of the members. So we're going to move Mr. Kitchen for 2 minutes.
Thank you, Mr. Chair. I appreciate this. I'm going to ask Mr. Jackson a question. And I see that you're the Director of Insurance and Risk Management. And after many years of being a hockey coach and having patients come to me in my practice and say, okay, I got hurt playing hockey, I have this Hockey Canada form and that came to me with concussions, and I'm dealing with it and assessing them, and they say, okay, how do I pay for this? Can you explain the challenges that you have in Hockey Canada on that form?
Yeah, certainly, and it may be the insurance-based form that you're talking about. Certainly we require that to be completed in a claim situation, and certainly there's always the challenge of getting it completed efficiently. There's always the challenge that players have to go see a physician in order to get that completed. There's the process of getting it obviously into our offices, into the Hockey Canada offices, and the process of reviewing each of those forms. So there are many challenges around it.
Form allows for physicians, for chiropractors, for physical therapists to fill out and complete, correct?
Yeah, well, it is meant for physicians. We do get other entities. There's no question filling out that form, depending a lot of times on what the injury is as well.
Right. The form doesn't stipulate that, though, but it does allow for other practitioners to point that out. And I think when we're dealing especially in rural Canada, where we're dealing with injuries that, again, where you have a practitioner who doesn't understand the sport, and will often refer to somebody who does, who might be an expert in a sports injury area to assess that. And that may be the chiropractor or the physical therapist in that community to fill those forms out. And you would accept those as insurance, correct?
Thank you, Dr. Kitchen. We're moving over to the Liberals now and Mr. Erskine-Smith for 2 minutes.
Thanks very much. For Hockey Canada, so I played baseball growing up, not hockey, and in baseball, there are accidents that happen with respect to, and concussions do happen, but it's not really in the course of regular play. And so I appreciate answers to Mr. Fisher in relation to hits to the head. But when a concussion happens in youth sports here in Canada, what's the reporting mechanism so we have a global picture of what's happening?
So if a player suffers a concussion, obviously we have a very simplistic message that we teach our safety people, and that is, if in doubt, you sit them out. So they are pulled out for that game.
Reported to so that there's a clearer picture at a national level for Hockey Canada as to how many concussions are happening at the local level.
And there's no specific surveillance, and I can tell you that one of the biggest challenges is surveillance. When you start to talk about collecting that kind of data, it's very difficult to get in a lot of times people to fill out those forms, to submit that information. So one of the biggest challenges we have, and I know that
Has been made to go down this road of ensuring that where concussions do happen in youth sports, there's a central reporting mechanism to Hockey Canada, and you are able to collect these statistics?
Right now, we actually sit on the FPT working group on concussions. That's one of the big topics they're looking at is surveillance, and the reason for that is that, just as you're saying, data is important. We need to know what's happening out there. So we're going to see what comes of those discussions and other discussions. But certainly, as I say, surveillance is one of the biggest challenges. There's no question.
Thank you, Mr. Erskine-Smith. And we're going to thank Dr. Bauman now, because we're going to lose the video feed in about a minute or so. So thank you very much for your testimony, for your answers, and anything else that you would like to submit to the committee. Please feel free to do so. The report will be put together and hopefully will be tabled in the House by the end of the spring. Thank you. We're going to move over to now Ms. Hardcastle for 2 minutes.
Thank you. Dr. Aubrey, I just wanted to go back and ask you a little bit more about the consensus statement on concussion in sport. Is this something that you think needs a concerted effort to be updated and adopted? You said that one of the milestones was in 2012. It was the first time that we discussed, I'm saying we collectively, parents, trainers, whatever, doctors, it's the first time that was actually articulated that someone who'd been hit in the head didn't return to that same game.
That's right. Yeah. So the consensus is actually an international document that is produced by experts around the world following the 2-day symposium, and they give a consensus on the evidence that's been presented. For example, in the last 2016 Berlin consensus, over 64,000 articles were reviewed, and from that, then a consensus which is based on scientific evidence. Those guidelines are really So related to scientific evidence. They provide the current status of what we know in concussion, and they really form the basis of other groups, for example, such as Parachute, such as Hockey Canada, giving their guidelines, because they will usually follow the consensus, which kind of becomes the, I would say, the leading document on the field, so that different groups can then look at it and adopt it or adopt some parts of it.
On behalf of the committee members, we want to thank Dr. Aubrey. Mr. Jackson, we want to thank you for your candor, for your openness, for your willingness to be here, and for your answers to the many questions. We appreciate that. And again, the report will hopefully be tabled in the House by the end of the spring. Thank you for your recommendations. Anything else you would like to submit to the committee? We're open to receiving those. Thank you.
Thank you.